actually. It's going to take a picture of him and that. Is it showing up nicely? Okay. Because my slides kind of washed out on that screen over there. They were white, but if you see him there, then it's perfect.
Cool, let's get started.
All right. I'm going to go check the door.
Okay, thanks.
And probably, when do you want to close the glass door? Or you want to put a note on there to call you?
No, my phone is on.
Because you're transmitting.
My phone is on Meetup.
Oh, you know what? I have a phone. I have a bell. Like that bell. I can give you that. And so if somebody comes up to the door and
Cool. So let's get started.
So did you figure me out as soon as I walked in? No, let's go. So that passed. So was all. Oh, you're fun.
So this meetup is sponsored by my company. My name is Dennis Dicker, the founder of Optonome. It was named after these two words, optimum, autonomy. So in home healthcare, we want to try to support people so they're most independent, have optimum autonomy. So that's where we came up with the name. As we built out the platform, I noticed that there were three main functions of the platform: communication, training, and management. These are the three main features that are needed in the home healthcare space that you'll notice as we talk about the problems in the industry and why there needs to be some type of solution, if not a disruptive solution, so that more people can receive healthcare, as well as not only individuals with disabilities, but also seniors. As more and more seniors require healthcare, the current systems that are in place are not enough. So we'll talk about that shortly. I'm a computer engineer. I'm not from the healthcare space. Growing up, I used to play around with a lot of technology tools. I built a website in the late 90s. I put my mother's clothing company online. This was the late 90s when I was in my early teens. From there, I went to school for computer engineering and I started investing in real estate. And so after finishing my computer engineering degree, I went into focus more on real estate as well as research and technologies for the federal government. And this gave me a lot of insight as far as the types of technologies that are out there, what are being used, not just in the healthcare space, but by a lot of these companies like IBM, Google, that are being used for mainly a profit. So that's where I got the desire to really start to figure out a way to use not only technologies that are being used for profit, but for social good. So that's where my desire came from.
Excuse me, whoever runs the building, can they turn the music down so I can hear
Oh, yeah,
better?
sure.
Sorry, interrupt your flow there. My mind was computing. Yeah. Especially. Yeah. Well, right now, we're going for
Sorry, we're back.
So going far as home health care and adults with intellectual disabilities and autism, the reason why people, the transition phase from hospitals and institutions to the home is, for one, because of cost. To have someone in a hospital is 3 or 4 times more than to have somebody in the home. And in the early 1900s till the early 90s, not too long ago, there was an institution called Penhurst out of Pennsylvania. I don't know if you heard of Penhurst, but we can actually, I wanted to actually Google Penhurst so you can see. So the first thing it says, Penhurst Haunted Asylum. That's not a good thing, right? Alright, so Penhurst was actually an institution that that housed a lot of children as well as adults with special needs, and they basically tortured them. And so once there was an article by a local news station outside in Philadelphia that did about a 4 or 5 part series on Penhurst, and that started legislation so that individuals can get better care, not only in institutions but in the home health care setting. And that's when more legislation helped pave the way for waiver programs in states. And these waiver programs, like Texas, like Pennsylvania, like Tennessee, they allow families who have family members with disabilities to find a home outside of an institution where they can receive care, where they can live an independent life. And so that's these waiver programs. There are over 40 Medicaid waiver programs in the USA, meaning Medicaid allocates funds to these states where they can use those funds to create programs to support these individuals where they do not live in institutions. So it's their best interest not only to help them live a more independent life where their health and safety conditions are better, but also save money where most states have to pay these hospital bills for these individuals. On top of that, there's a family burden. So most states cannot afford all the people that require health care in a home setting. So families have 2 choices. Their family member can go to an institution. They are accepted into a waiver program, or they take care of them. So currently there are more than 50 million family caregivers right now that care for their loved ones, not just adults with special needs or kids with special needs, but it's also seniors and their family members. So there are over 50 million. And the cost of family members not working, taking off of work, caring for their family members, the combined cost is $500 billion. So it's basically saying that everyone here probably care for someone and probably took off from work or probably transferred money to someone's account to help a family member care for their loved one. And like I said, from my home health care experience, I was one of these Medicaid waiver providers. So in early 2011, I noticed that there was more of a focus on seniors, and there wasn't a focus on adults with autism or intellectual disabilities. And so actually starting the agency was very difficult. It took me about 2 years to maneuver through the regulations in Pennsylvania to really understand what was needed. And the reason why I did go into the space was, one, I had to care for my mother when I was at a young age. She died from cancer, so I had to actually care for her during that phase. And two, as I purchased more homes, as far as real estate homes, I noticed that there were a lot of people that needed housing, and I noticed that there were a lot of adults with intellectual disabilities that needed housing as well. It's not just the health care. So me being a real estate developer, I felt that I could not only provide health care, but I can also set up homes so that these individuals could live. And so what we did was we actually licensed homes, meaning it was similar to a nursing home, but it was in a residential setting. And it allowed someone that was otherwise living in an institution to live in a home, in a residential setting. And so when we started to provide healthcare services to them, not only were we focusing on training the staff workers, but we also had to figure out the different behaviors that came along with that person. The current systems that are in place do not allow staff members to document the changing behaviors in real time. This was very difficult for me as an executive director of my provider agency. And I wondered what was going on as far as the industry and what were they doing to actually help these individuals. Because if you're documenting on a piece of paper, if something happens inside the home, how can you communicate that information properly to not only a psychiatrist, a behavioral specialist, or a doctor, but your supervisor? You know, it's close to impossible. You know, if you verbally explain that information to someone of what happened, it's hard to clearly explain what has happened in that situation. And I can give you all types of examples. So this is the main thing that was problematic when trying to support someone with intellectual disabilities or autism. And this is clear stats across the board that was also shared with Donald Trump in a report. And this report basically talked about the DSP crisis. DSPs are direct support professionals that are also called personal care assistants, caregivers, home health aides, or certified nursing assistants. But they are trained to actually administer medications. Certified nursing assistants are not trained to administer medications. They place medications on the table, and then the person has to administer, take the medications themselves. So there's no way of really documenting if that person took the medications properly, because these certified nurses assistants, they're not trained to do that. So as far as the staffing crisis, all these providers in all these states, they have a turnover problem. 45% leave within that first year. And so because of that turnover problem, they're stuck in a cycle of continuously training direct support professionals so that they can continue to provide services. If they cannot provide services, they will lose that referral and then end up closing down because they can't afford anything. And so what they're doing as a result is they're hiring people to train, but they're also spending a lot of money on job posts, overtime as well, because there's a vacancy, and a lot of people don't want to become direct support professionals because they're getting paid close to minimum wage, as you can see. In Texas, here in Texas, they're getting the hourly mean wage is $8.65. How can you afford, to buy a house, or how can you plan a college education, or buy a car, or let alone care for your family? So these workers are depending on the government. They are depending on Section 8 housing. They're dependent on food stamps and things like that. And so now you have care workers that are dependent on the government, but now you have the actual individuals who need care that are also dependent on the government. And this is a continuous cycle. And it's just really a waste of money. So me as a provider, and also being having a technology background, I started to try to figure out ways that I can improve the situation, not only for myself, because I was also stuck in this loop. Because coming into it, I didn't think that people actually budgeted for overtime, or budgeted for hiring and training these people, knowing that they would quit. On top of that, there's a housing crisis, like I said earlier. Individuals that are on Social Security, the average payout is about $750 per month, and the average one-bedroom is more than that. And so as a result, these individuals are living with family members, living in basements. They are living with friends and family, and that's how they end up homeless or back into an institution. So now you have housing crisis, direct support professional crisis, and as a result, the individuals that actually need care because of their autism diagnosis or intellectual diagnosis, they cannot improve. And as a result, you have also these individuals who are living at home and cannot find work. So I dealt with all these problems. Any questions so far? I know you have questions. Sure.
So, I would imagine that a lot of these special behavioral issues, they actually end up maybe on the streets and then eventually into prison system.
Yes.
Where that's their institution, where they receive
The proper
any,
meds.
if any care.
Right.
What do you do when you have like a terminally ill patient or someone with like Parkinson's or Alzheimer's where like a person with Parkinson's is not just doesn't have a behavioral problem that would cause them to go to prison, but they can't just be home. They'll essentially will survive on their own.
They need some type of supervision.
Yeah, and I have personal experience with this because my grandmother had Parkinson's and for a very long time, and eventually she needed a feeding tube. She'd often pull it out. There was a caregiver who was able to at least replace the feeding tube, but that also might require a trip to the hospital. And I can see another reason why these
So it's the same for people with Parkinson's, dementia. If someone needs care for 5 hours a day or care for 24 hours a day, with this type of turnover, it's hard to stay consistent so that this person or whoever this person is that needs the proper care, they can steadily improve. Each time there's a new person that comes in, it's like have to start over. The rapport has to start over. They have to really figure out what works for that, not only for the worker, but for that individual that needs care. And that takes time. And especially with the current systems that are in place, someone has to train that person not only on state regulations so that they can provide the proper health care, but they have to train them based on that individual's needs. And each person is different. You can't train someone to care for someone with autism or Asperger's, to care for someone with Parkinson's. You cannot do that. Not only is their diagnosis different, but they have different likes and dislikes. They have different goals that they want to work on a daily basis. They have different activities that they want to work on. So the current systems that are in place, it's really hard to continue to help that person not only improve but have a better quality of life on a daily basis. It's very important. So from there, I wanted to talk about as far as what's available. Home care, home base. The reason why I wanted to do this meetup here in Texas, Dallas area is because a lot of these startups are from this very area. And Texas is one of the most, let me think of it right now. As far as home health agencies, they don't allow any more home health agencies in Texas because they're the most corrupt. They have the most issues, and a regular electronic health record software does not do enough. There needs to be more than just an electronic health record to help document the progress of a patient. And that's what Home Care Home Base does. That's what Meetup does. And that's what Clear Care does. So we can actually, are you familiar with any of these? Are you familiar with any of these?
Indeed.com.
Okay.
That's more of a job.
Yeah, we're going to get into that.
If I got this straight, you said the problem with Texas is just the level of corruption.
It's the same it's the same in all the states, to be honest. And I'll get into that. No, I'll hold on, this just kind of went out. Interesting so far?
Yeah,
Yeah?
absolutely.
Cool. That's what I like to hear.
And have you or your company personally, back to the prison question, have you,
I've actually been to these institutions we receive referrals, and I've actually been to the institutions to interview the patients before I take them home. So it would be me, an individual, and they were extremely on drugs, on all types of stuff. It would be very difficult for them to say a complete sentence. Most of the time when I met with them, next time I met them, they didn't remember. So when you're in these institutions, they have rooms that are all locked. Like the one person cannot go to another room without someone unlocking the door. TVs are boxed in, so no one can break them. Chairs are screwed to the floor. Tables are screwed to the floor. They have no sense of freedom. They have set schedules that they have to abide by all the time. So when they come out of those institutions, they really need that same consistency. Not the same lockdown atmosphere, but the same systems in place to give them not only the autonomy, but the ability to make some decisions without in freedom to live a daily life like you and me, and that's the goal.
So, is there let's just say I'm completely ignorant of the situation. The halfway house. I thought that was supposed to be kind of helpful transition of an institution into back to the world independent living, and yet that does not seem to be the case.
No, not at all. So as far as no, that's not the case. It's either the institution or a home healthcare or residential setting. They do have intermediate settings, but those are on campuses, and that's still considered an institution. So if you want to receive funds from Medicaid, it has to be in a residential setting, as that particular funding model, it does not allow you to live on a campus or institutional setting.
I've had some experience within in a residential setting, and the communities really don't want it. I mean, as soon as they hear that there's something like that going on, they
Yes.
do not want it there. Are you going to address that as well? Because that's a very big problem too.
I agree, and that was one of the things that I had to deal with when we had homes in residential settings. And it's really community outreach, letting them know that staff are trained properly if something happens. We are in direct communication with first responders. We do know CPR, first aid. We do know if there's an emergency situation, we'll have the proper supports in place so that nothing happens to the local community, things like that. And it's that stigma that's what's going on right now
Sure.
that people are scared of, and I do understand, because it is really difficult to care for someone that's supposed to be, or usually is in an institutional setting. And it goes into to the types of systems are in place. If someone has a behavioral episode, if the care team that's supporting that person, if their type of communication is documentation on a piece of paper, how can a behavioral specialist properly come up with a plan for the support staff, if they don't know what's really going on in a real-time situation? It's close to impossible. So most of these products right now, Clear Care, Therapy, Care Home Base, they are starting to focus on providing real-time solutions, but there's still room for error, and we'll get into that. As well as training to help care workers, to help providers save money on training. Reliance Learning is a leading company in this space for home health emergencies. trainings for home health agencies so that they can simply have the care workers go through these courses so that they are in compliance. So it saves them that money, that training costs, but there are still some training courses that instill some communication between the administrative staff in order for a person to start working in the field. Indeed.com, which everyone knows about, is a job posting site. I wanted to go into Indeed.com right now. Let's see if we can see that. So we're going to look up, direct support professional. Let's look in a whole. So right now there are close to 2,500 job postings for direct support professionals just in the Dallas, Texas area. And as you can see, they're offering $10 an hour. So Indeed is one of the main sites who banks off of the home health industry. All these providers are spending at least $30 a month, where someone posts a job, they wait for someone to respond to the job, then they ask them to fill out a job application, and then they ask them to come in for an interview. Then after they ask them to come in for an interview, they say, oh, okay, we're going to check your references, and we're going to check what types of certifications you have. So all of that you're doing for someone that's 50% chance they're going to leave. So you're paying someone to do all this, and it's coming out of the agency's pocket because that person didn't actually start working. On top of that, once they're finally hired, there's probably another 25% chance that the person that they're actually providing services to won't like it. So it's a high probability that you're wasting a lot of time before hire. So Indeed.com, Reliance Learning, even though they do provide solutions for the healthcare field, it's not really helping. It's not really helping these providers lower their administrative costs so that they can focus on caregiving and helping these individuals that need care. So we could look at Pennsylvania as well. So in Pennsylvania, it's over 7,000 job postings. And that's pretty close to what the stats say. As far as there are 73,000 employed workers, and there's about a 11% vacancy rate. So that's 10% is about 7,000. So that's about right. Just 73,000. So that's actually pretty close, pretty accurate.
Okay, so what boggles my mind, over $2 billion spent each year on recruiting and rehiring.
Yes.
How about paying those people a little more money?
They don't see it that way because they're stuck in that cycle. Because they're already losing money. So they want to, so once they're hiring someone, they already have a need to put that person out in the field. So they're already losing money. They want to put them out in the field as fast as possible. So if they pay them more, they're not only they not only have still a chance that that person will leave, but there's also a chance that they will not fit right with that person needing care.
But the money's going out anyway.
Right.
If you're spending it on the people doing the work, then there won't be the turnover and you get a higher caliber person.
Right.
So
the best thing to do is to start out with the right systems in place, because if you don't have the right systems in place, you're going to have too many administrative staff that you're paying money on, and that's the problem. most of these provider agencies don't have the right systems in place. So they're spending money on the administrative staff, and that's why they cannot spend the money on the actual workers out in the field.
Big enough.
That's the problem. And so when you have, after you're training these people, you still need someone to train them on these systems. If you're a provider agency and you're using home care, home base, or Thera, you still need someone to train them on the system. Because you have someone that's was working at this agency that was working on this system, and you have this agency that's working on a totally different system. So someone has to not only train them, but they also have to train them on that individual that need care. And so that's another maybe 10 to 20 hours that you're paying an administrative staff before hire. And so this is why that they're going deeper into the hole, and they have no choice of really improving care. So these are really the top systems that are out there, and these Clear Care, they raised maybe like $50 million.
Big what?
About $50 million. Clear Care.
It costs $50 million?
You know, they raised $50 million to come up with a solution for home health care. And just to build a solution for home health care. And they are still missing out on one of the main parts, which is not only helping train, but also figuring out how these care workers can get an increased pay. Like I said, you can provide a solution for these provider agencies, but they can still turn around and pay these care workers $9 an hour. So one of the solutions that I built with my home health agency was back in 2014 was we started to provide an app on the iOS and Android, so the Apple and any other Google phone, and it trained anybody in the general public, because I noticed that it's not only the care workers, but there are family members that need training as well. So it allowed anyone to start training so that they can care for their loved one or they want to find work. And what this did for us, it helped me reduce our training costs, but it also reduced our overtime costs, because we now had a pool of people that were trained and were looking for work. And so at that time I was focused on my home health agency. But then we started to realize that there were other people in the industry that also needed care workers that were trained. And so we started to share these workers with other agencies so that they don't have to train. And we can help share these workers so they can start working a lot faster. And so by putting these care workers through this type of training program, we kind of created an apprenticeship, not only training people to provide health care, but we also trained them on the application that they will use to document health care while in the field. So those two problems we eliminated. We did not have to train them again once they were hired, but they were also ready to start working once they were hired. And so that's those two problems that we see right here.
How was the training given? Was it computer based? Was it?
So it's online. It's an online learning. It's a combination of online and offline. So people start off online where we can view their progress, and as they progress, we can see analytics on how fast that they're completing courses, if they really care to finish the courses, and then we can really see if we want to bring them in for it. Once we interview them and we feel as though that they are ready to start working, like I said, they already understand how to use the application to start working, but then we can further train them on the individual needing supports. And we can send them out to a location where a person is currently working, and they can shadow someone and actually test and document without even working. So it's on-the-job training as well. It's a combination. So we were able to.
So that should automatically warrant them getting more money.
Right, because they additional training.
Exactly. The cost of that burden is not on the home healthcare agency anymore. But I'm gonna get off that topic.
But,
Oh no, let's hear it.
well,
Yeah, I'm saying with the training that you're giving them, that should automatically warrant a pay increase, okay? Because they're only
Yes,
trained.
right.
The agency doesn't have to do it.
Exactly.
The chances of them leaving are fewer.
Right.
Sounds like a pay increase to me. I mean,
Right. So what we did was we were able to not only train them on entry-level direct support professional services, but using the technology, we were able to help them document supervisory or manager type services.
Awesome.
So they were able to, we were able to basically eliminate a supervisory role, and we were able to pay these workers living wages. And they loved it, because not only were they able to learn advanced skills in the profession that they're interested in, but they had the skills that if they decided to leave this agency, they could use those skills and advance somewhere else. So it was a win-win for everyone.
Yeah.
So we had built-in state regulations where these workers were able to document healthcare services. So this was actually documentation. Try to. So that workers actually documented this while working. And these are state regulations. And it helped, usually these things are done by supervisors or managers. And so now that we've given the tools to these workers that were before getting non-living wages, we're giving them the skills because of the tools that they're now using, that they know how to use, to now not only provide better health care, but save the administrative team money, time and money. Right? So as workers are working throughout the homes, they now are able to document state regulations so that when auditors come inside the homes, they can share this type of information. So this was a regulation because, believe it or not, in home healthcare settings, utensils are sometimes not clean. Sometimes there's food not in the refrigerator. Sometimes there are slippery surfaces. And so to be able to document that these things are in place in a 24-hour period is really crucial, because someone with behavioral issues need those types of things in place. If someone is with behavioral issues does not have their meals at a certain time, there could be some type of behavioral episode that needs intervention. So while we're on behaviors, if you're in a setting where a person has a behavioral episode and requires some type of intervention, there needs to be a way that the actual care workers knows the antecedents and knows what type of intervention to provide at that location, and also based on that person's needs and goals, what will help them overcome that behavioral episode. And you're unable to do that with paper. It's impossible. I know many behavioral specialists that still distribute behavioral sheets and behavioral support plans that these workers are supposed to remember while working. And I'm pretty sure 75% of these workers forget about what types of interventions to provide when the actual behavioral episode occurs. And so this is an example of if there is a behavioral episode and staff need to document what's going on, how a behavioral specialist can see in real time what's going on and possibly help the care workers not only provide an intervention, but be able to care for that person before first responders come in.
Could you maybe just walk through?
Sure. So this is a scenario where a person has a doctor's appointment and they are leaving the home. They're leaving the home right here. So this is a 2-to-1 where two direct support professionals are caring for this person. So he has very difficult challenges. We care for many people that needed 2-to-1 care. And it's needed because in some cases you have someone that not only will try to test one care worker, but you'll need them to switch places at an instant so that they can try to continue caring for that person. And so this is the care workers actually documenting and it's showing up inside the software and them being transported to a doctor's appointment. So once they're at a doctor's appointment, they can continue to document what's going on, and the doctors can also see what's going on. So if they're behind, or if something is going on, the receptionist at the doctors can actually see what's going on and help them get to where they need to get, or see the doctor as soon as possible. Seeing the receptionist, if the person's behind schedule, that can also trigger an episode. It's being seen all the time. And so, one thing that I did not talk about yet was the ability to track care workers inside the home. Being able to communicate where care workers are inside the home is really crucial. And like I said, these systems that are currently being used, there's really no way of tracking workers inside the home. So one thing we started to test was sensors that help communicate location information of where the care workers are inside the homes. Because you would have care workers that sleep, you would have care workers that need to check on a person every 15 minutes if they're inside their bedrooms. And if something goes wrong, there can be some type of allegation of abuse or neglect, which puts the agency at risk. And there's a possibility that they can lose the actual patient if it gets worse. And so there's a need for the provider agency to ensure that the direct support professional is at that place at that time. And that's another reason why direct support professionals quit, because if there's an allegation by a family member or any type of third party, the burden is first from the agency. What did you do? And the direct support professional is like, what? I did my job, or whatever excuse they would make, and the first thing they would do is say is, I quit. That's what they would say. Why do I have to deal with this? I'm only getting paid $9 an hour. So that's another reason why there's this turnover problem. And so what we did was we put beacon sensors inside homes so that we can track workers and we know where workers are while on the job. So while they're clocked in, we're able to see remotely exactly where they are inside homes. So this is one way of doing it. The other way is actually sending a supervisor on the site to actually see where they are. And to actually have a supervisor on site, you might as well just have the supervisor do the work, which is an additional cost. So with workers, while they're on site, if it's time to administer meds and they fall behind schedule, with the sensors, we're able to alert not only the worker, but someone in the vicinity, if they're not at the site, but remotely, that this person is behind schedule with administering meds, and they probably could send someone there to administer meds, because if someone actually forgets, it's an actual allegation of neglect. That's another incident that needs to be resolved by the agency. They can lose their license. So there are all these risks that comes along with the reason why someone would think, why should you open up a provider agency? There are all these problems, right? It's too difficult, even though it could be profitable if you do it right, but there's so many risks that come along with it. If you ask any provider, they would say, I'm not going in to provide 24-hour care because the risks are too high. But that's where the need is. These people need 24-hour care so they don't live in institutions. There are many people that need maybe a couple hours a day for their diagnoses, maybe just to help with medications or appointments. But that's where a lot of them don't have housing. They can't afford a home. So they're still dealing with that issue.
What's the difference in the amount you can get from Medicaid or Medicare for a patient that should be institutionalized, but we're doing it in a residential service, versus somebody who doesn't need that kind of care?
Okay. So for someone that needs maybe 5-10 hours of services a day, the average is private pay right now is around $20 an hour. Medicaid waivers pay between it depends on the service. Companion services get about $20 an hour as well, but more advanced services like direct support professional services is between $30 to $40 an hour.
And that's what the agency receives?
Yes.
You as a provider?
Yes.
Okay.
Yes. And it varies by state. And these are for services that for someone that needs a couple hours a day. If someone needs 24-hour care, the average rate starts at between $400 and $500 a day. So that's where you start to have to budget, and that's where you really need to figure out as far as administrative costs, how can you really pay workers properly.
So these licensed residential homes that you have, is it just one person that resides there, or are there like multiple people?
You can have multiple people inside the home. It's all based on the state regulations. The home needs to be at least 10 by 10, the room. There has to be a kitchen. There are certain regulations in place. But what we focused on was 2 bedrooms, 2-bedroom apartments, 2-bedroom homes, because we didn't really want to put too many people in there.
Right.
But you could have 8 people in it if it fits.
So the one example that you used where you had 2 DSPs to one person, they would be in like a home with another person too?
So that type of setting, we put a person in a 2-bedroom home by themselves.
Okay.
We just so that person, it depends on their transition out of institution. So the plan is usually once they transition out is they live by themselves, and then transition them into a setting where they have a roommate. And then from a roommate, they can probably live in a home where they're not receiving 24-hour care. So that's how the process goes.
So they move throughout different homes in your actual agency?
You can. We had a person actually at one site. We had like 2 apartments, the first floor apartment, second floor apartment, where once the person transitioned from 1-to-1 by himself, we gave him a roommate on the second floor.
How do they respond when they're with someone? Like, because I would think being in an institution surrounded by people all the time and kind of living on your own could be a bit of a shock, I would think. But then to see them transition to a roommate, how does that like affect their behavior?
Okay, so if you're living by yourself from an institutional setting, like we said, we try to have, you're not always, well, most times if you're in an institutional setting, you're starting off with at least two people at a time because of behavioral issues.
Right.
If you don't have that behavioral issue, it would just be one roommate. You could possibly have a roommate. The reason why they live alone is because of behavioral issues. So if they are in an institution, they will probably be by themselves because of their behavioral issues. So once they're in a residential setting, you usually put a plan in place where they can, sometimes you try to put them in a day program during the day where they can be around other people. But sometimes they're not ready. Where if they're not ready for a day program, you do activities with those workers in the local communities, like go to parks, go to places that are not busy with a lot of people. So most of these provider agencies, it's hard to really plan these things using these types of systems that they're currently using, because how can you really monitor what's going on in the local area?
Right,
You
it's
know?
spontaneous.
It's spontaneous. It's
Real time.
impossible. It's impossible. And that's one of the things that I had to deal with because I had someone that was more on the Asperger side, really intelligent, but he could not be around people. He couldn't be around kids. So if he's around at a park where there are kids, he could flip out at any given moment, and cops could be called. He could possibly be in jail, which we don't want. So as a provider agency, you're putting yourself at risk at all times without having the right system.
So the question I see in your slide, you use the example of rule of five. So I'm assuming maybe your patient has some sort of psychotic disorder. So you've already implemented this type of system in someone who actually has just a mental disorder. These people, when they go on their meds, they tend to start to feel that they don't need their meds anymore.
Yes, that's true.
And I guess, how do you deal with compliance?
So as far as compliance, if they deny their meds, we as a direct support professional, we have to document it. And you cannot force them because that's considered a restraint. If you like try to force them into taking meds, you cannot do that. Well, Pennsylvania state regulations, you cannot hold anybody down for more than 30 seconds. So if you try to hold someone down because of their behaviors, more than 30 seconds, it's considered abuse. So if you force them on meds, it's considered abuse. But if they continuously do not want their meds, they just need to know that they will end up back in the institution. So most of the time, they will start to comply and that type of. because they want to be outside, they want to be home.
So, and you have data that they, that the majority of the time they eventually comply.
Yes, but they usually do have behavioral episodes that lead them back in an institution. Yes.
Because if their psychosis is,
Parent voices.
well, or delusions.
Delusions.
This person is actually works for the government and wants to like ship in my next
Something like
away,
that.
I'm taking this meds.
Right.
Or that they would have to be institutionalized.
So the one thing about direct support professionals is they really try to teach the patients or the clients or the consumers what they're taking, so they understand how it's helping them improve. They not only they don't just be a companion, but it's more of an educational caring where they help them reach their goals. So these goals that they work on a daily basis are tasks that the patient not only agreed to, but want to participate in. So they're not forcing them to do these things, but it's helping them participate in activities that they're interested in. So when you take the meds, they know that it's helping them work on the goals. And so, just wanted to go over a little bit more, maybe another 10 minutes or so. But I wanted to discuss really how I believe we can really resolve this. It's called a DSP crisis. It's actually called a DSP crisis. But also help realign the players in the home health industry and help anyone that want to care for someone that has a senior or someone, a family member, or someone with autism, they're able to set up a home or open their home so that they can care for someone. Because one thing that I believed in when I started providing healthcare services is not only is everyone different, but once you get to know, get past the person's disabilities, really cool people, really, they're understanding, they want to do things like me and you, they just have disabilities or disorders that get in the way. So what the software does is start it out. So we started off, like I said, we started providing training to the general public. So the next step what we're doing is, because you can't really control each provider and how they're paying, we're starting to actually give the workers that are training through our software application incentives, because we want them to reach their goals as well. There's really no type of career advancement for direct support professionals. I know people that are staying in the same position 5-10 years are getting like 10-cent pay increases. It's terrible. It's just it's nonsense.
Right.
I don't know why it was like that, but like I said, I came into the industry from a different perspective, and I wanted to really change things. So I came in with an open mind to really try to build a solution using technology that's on the cutting edge. So now that we have online learning, it guides the workers through the onboarding process that's currently being done by administrative staff of these agencies. And these administrative staff are trainers, HR. I've been through about 3 or 4 HR professionals while running my agency. I had to literally train them on the regulations so that they understand the compliance as well as, which is totally separate from hiring and training workers. Compliance is totally separate. Once we built it into the software, we did not only need a trainer, we didn't need an HR. We didn't need an HR. So we started to automate the back-end administrative tasks of my agency. And at close to the end of when we started to provide services, it was me and a program specialist. That's it. And a program specialist is the required healthcare clinical person to run the agency, and everybody else was contractor. We had a nurse contractor, we had a behavioral specialist contractor. So the only employees was two of us. So everybody that was training through the system, we were able to quickly put them out in the field because they not only knew the regulations, but they knew how to document based on the individual support plan of that person. So they were now able to provide meds, administer meds, and document the regulations. And so the next step was to figure out how can we resolve, once these workers continue to work in advance, how can we focus on the problem of finding homes for these individuals? And how are we going to continue to pay for these incentives to help these workers not quit? Anybody can download an Uber app and start driving any day and get paid $15 an hour. Why would they work for a provider agency for $12, $13 an hour? We want to keep them in this field because it's not only a growing field, but more and more people need care. So what we're doing is we're providing a social impact component for the health industry, and we're doing that through crowdfunding. We're doing that through crowdfunding where we help. You listening?
Yeah.
We're helping real estate professionals that are looking to renovate properties. Right now, what they do is they get loans from hard lenders at high returns, and there are many people that not only flip houses, but they look for these hard lenders to offer 25% return for investment. So what we're doing is we are crowdfunding these loans, and percentage of profits are going towards the home healthcare industry. Got that?
Got it.
So think of it as a bank or a hard lender. Hard lenders basically give if you have a property, and say if you have property that you owe $50,000 and you want to fix up that property so that it could be nice, where you can rent it out to someone or you can sell it. You want to put some equity in that, some hard improvements into that property so it's worth it. Say if that property after you renovate it is worth $125,000, and you're looking for $25,000 to improve that property. What you'll do is you'll look for some type of loan somewhere. Most banks are not going to give you that money because of the loan to value of the property at the time is too high. So most real estate professionals, they go to hard lenders which will loan you money. Most of these hard lenders, they don't loan the money because not only are they getting high volume of people that are looking for loans, but also they're trying to minimize their risks. It's hard to really track the money once you give it out. So once you approve a loan, these hard lenders, it's hard to really track to see where that money is going. Someone could potentially use the money for something else, and then who cares about the property, you know? And so we are able to offer these incentives because we're able to, because of this right here. We have sensors inside the homes. So if we loan money to someone, we can not only track where the workers are and how they're improving the site, but we can also track funds with debit cards that we provide the care workers. And so if money is distributed onto debit cards, we can also track where funds are being spent, but also where it's being installed or improved inside the home. So we can track funds and make sure monies are returned so that care workers can be incentivized. So that's really our way of incentivizing care workers so they can be paid on it.
So, to get this straight, you find real estate agents that want to essentially flip a house. They come to you, to your company for a loan, and you give it with their guarantee that they install these sensors. Is that
Yes, that's part of the loan.
part of the
So
loan?
they as part of the loan, they are required to install these sensors inside the home.
And so how do these real estate agents actually profit from that?
So this is a site right here. This is similar to what we're doing. It's called Patch of Land. And they're getting tons of money. They keep all the money, all the profits to themselves. I think last year they made about 80 million, something like that, from just profits. Imagine if a portion of those profits actually went to these direct support professionals. So that's that social impact component that we're adding. Because there are tons of people that are looking to renovate properties, not only for themselves, but for a profit. There are many ways that you can exit. You can get a refinance. As long as the equity is in there, there are plenty of banks that are so what they do is they offer people that want to invest, they offer them a percentage, say 12%, but they maybe charge the borrower 20% something. And so the investors get a return on their money, which is higher than most banks. And this is where the industry is going. More and more people are investing in real estate to get returns without going through the hassle of actually going through the renovation process of real estate. So you can put your money in and get dividends every quarter. So right now we currently have people that are investing and getting 25% return on investment, which is, you know. And so we do that because I'm getting enough profit, because I'm not a real estate developer, I'm getting enough profit to still pay for improvements on the software. We're using the same, I've been doing this for years now to develop the software. And we did it while I was running my home health agency. You know what we did? We were able to help people who were on waiting list for Section 8 to live in a home. We were able to give them activities that they couldn't afford, and really help them reach their goals a lot faster. And that's what's really the real goal is. If you're a home health agency or you provide a support for someone, you can't really just come in or send a care worker to provide health care knowing that this person is living in a basement or something like that, or can't afford to go to the movies to meet other people. You know, it really is, you know, never understood it myself. And so what I did was I was actually selling homes. I bought homes and sold homes, and profits that we made we put towards not only improving the care workers' rates, but we also help the actual individuals reach their goals. So this overall plan not only helps people in need, but it also helps people with housing assistance as well. If you don't know, Section 8, most people that are providing these services are in Section 8. And I don't know the stats in Texas, but Pennsylvania, the waiting list is about 100,000 people. So this is a way of using funds that is otherwise being used for profits for large corporations to actually give back and help individuals in need. And it's all done by software. So what you think?
So what if the person's goal is to eventually live on their own?
That's the goal right there.
But they still need family or maybe even a patient themselves is not quite ready to leave the sensor,
So
themselves.
they are totally fine trying things themselves. So what we have is this is what we offer adults that want to become that are more independent and maybe don't want sensors in their homes. We offer so I called it when I was running my agency, I called it a fresh start program because I felt like the people needed a fresh start from their current conditions. But we changed the name to Life Skills 24/7, and it's not like they're being monitored. It actually helps them manage their daily activities. So say if your schedule says that you want to cook your own meal for lunch. Once you get to the kitchen area, it'll actually show you step by step on how to cook that meal that you want to cook. Right? So it's not like you're being monitored. It's actually helping you complete tasks of daily living that you want to do to become more independent without an actual care worker there all the time. When it's time to do laundry, you need to know step-by-step tasks based on ABA strategies to be able to sort out colors from whites and be able to properly start the laundry, the washer, the dryer. Maybe you want to share that task with family or friends. And so that type of game component is in the life skill. It doesn't seem like you're really being monitored. And I've been working on this gamification component for a while now because people don't really want to feel like that they're working or they're using some type of electronic health record application like I was showing you. It shouldn't be like that. It should be some type of facing application that's fun to use.
So what is the interface? Is it something like a mobile app? Is it a tablet that they use? How do they actually get those instructions to cook a meal?
Okay. So kind of skipping. And so when I was building this out, it first looked like Facebook, and then it kind of switched over to how Twitter looks, like a feed, because I needed something where everybody can easily understand. And then right now we're currently working on how it looks similar to Snapchat, where it's a live stream, and on the left side you see your tasks that you're supposed to complete or that are coming up. So you're able to see the actual tasks that you have on your calendar. so these are different for each person. This dynamically changes not only on your care plan, it changes based on your location, it changes based on your mood, it changes on what you like, what you don't like, everything. So you're not going to get something, it's going to be something that interests you, like I said. If you're out in the public and you're hungry, and you want to find something that you like that you're not allergic to, that wouldn't tick you off. So this will help you find those places. So it starts off like this, and if you want to start to communicate with families or friends or a therapist or something like that, you can either call them or message them right in the application. And so it's built in, it's HIPAA compliant, and I really didn't get a chance to talk about the debit cards, but the debit cards also show them the way to budget and spend wisely while out in public. That's another component where a lot of people that are wanting to become more independent, they don't understand, how these advertisers try to sell you products, and then the first thing they'll buy is what they saw on TV. They don't care about the price. And so to be able to add an educational component as well as ensure that they're not overspending is really crucial, and it actually helps them become more independent without overspending.
Amazing. Very, very good work. Excellent.
Thank you.
So I have a question. Have you had instances where this fails?
So different.
Relapse.
Yeah, so as far as in the home, we had an instance where we had a new direct support professional that he did not, he wasn't communicating in the app. He didn't read all the notes in the application before we started from ending. So this person with Asperger's, he tricked him into going out, and they were out in an area where this person was not supposed to be, and as a result, a behavioral episode occurred. And if we were further along in development, we would have been able to not only create geofence, so we know where this person was when they left that area, but we will also be able to know in real-time data where they were going, so we can alert the care worker and let them know that this person's not supposed to be there.
So you can do that now?
I can do that. We can
Wow.
do that. And we're sharing these with providers, because you have these different instances where care workers would go, not only go places not knowing that it could end in neglect or abuse, or it could increase the risk of this person ending up in the hospital again, or even in jail. So these types of real-time data, but also the ability to know where these workers are and not allowing them to leave certain areas based on what tasks that they're supposed to be working on is really crucial. They're supposed to be working on, if they're supposed to be administering meds and they are out in public, you need to, this happens every day. It's happening right now. I'm telling you. It's happening right now.
Yeah, you're right.
It's happening. And this is tax dollars, to be honest. It's being wasted.
Is some of the feedback that you get that they feel micromanaged? Because I would feel micromanaged.
But now we're incentivizing them now. So it not only
The worker, okay, we're incentivizing
it's
them.
helping them
Okay.
not only lower risk, but it's helping them improve their work.
Right.
Before that was an issue, but now that we're incentivizing them, we're helping them be more efficient while on the job. They're not just sitting around doing anything. If they're sitting around and this person is asleep, we can easily give them a task to do inside the home. And document them
goal, but if they have some mood disorders, is there a way that you could program perhaps some sort of, like if they, let's say they engage in some sort of OCD or anxiety type of disorder?
Yeah, so that was another thing that we worked on. We had all types of people.
Yeah.
So there was this one guy. He would have issues late at night, really late at night, and we wouldn't find out till the next morning. And he wouldn't take his meds, but he would pace back and forth inside the home. He would go into the refrigerator. And so what we did was we put a sensor inside the door, and we put a motion detector in the vicinity, and it alerted his direct support professional to check up on him during that time. And he was able to get that independence to do whatever he wants, but if he falls behind, we could just find out what's going on and try. But that's we're trying to move away from that reactive approach to a more proactive approach, where when he's starting to engage in that type of behavior, before that happens, we can try to redirect him.
How would you try to?
Meaning we can try to introduce other activities that he likes. We can introduce something like maybe a family member calls him. Something that cheers him up so he doesn't get that anxiety where he will engage in that type of behavior. And that goes back into keeping the behavioral specialist inside in the loop of what's going on.
Right.
So when you have that type of system in place, you're able to be able to dynamically get that insight from the behavioral specialist and change these things based on what's going on.
So does your organization partner with certain behavioral specialists, like certain groups? Because I'm thinking, working in the provider space, I could easily see how somebody would be like, well, I don't have time for all this. I
Yes.
don't have time to look at all this documentation, but if you were to go in and explain what you're really about, you may have some groups that would partner more with you than others. So do you have those types of relationships with
Well,
certain
we've been
providers?
focusing on. It really has not been that difficult getting a behavioral specialist on board, because it saves them time as well, because they like to see sleep charts. They like to see what types of prompts were used for which antecedents, and they're able to see this type of information in real time. So right now they use that data and they go into Excel and they create some type of charts to create a report to share with everyone. And like I said, that's an approach that really is not benefiting everyone. You really want to help people in real time. So dealing with the behavioral specialist wasn't the hard part. It's getting providers out of this loop, to be honest.
Yeah.
They're really so old school. They really don't believe this type of solution is possible,
Right.
to be honest.
That's what I'm thinking about physicians.
They don't think this type of solution is possible.
Yeah.
Well, to redirect is very important.
Redirect.
Either with depressed patients who are starting to get, their meds are starting to work, take them out, but the meds actually, every antidepressant now has especially for adolescents, may promote suicidal ideation, and that's because they start out so low that they don't want to depression isn't just sadness, it's a withdrawal, every type of psychological process, even physiological process, so it's talks over, they'll either oversleep,
All types of things.
you might overeat or undereat, but once the medicine starts working, you get to a point that they're starting to say, hey, I can actually carry out this suicide. Before it was like I can't even think fully. So a person could go home thinking they're pretty behavioral
Interventions is crucial. It's crucial.
Especially if they need to know information, if they have firearms, they need to know their condition, their medication they have is counteractive with alcohol or, and I think through behavioral monitoring, you can see an individual who hasn't moved very much from what it's made, maybe retreating into their safe space, essentially. What the cognitive behavioral literature suggests is that they need to activate themselves. Maybe you want to take a walk.
Right. It's the right prompt at that moment.
Exercise.
You have to say the right prompt at that moment, because if you say the wrong thing or if you say something at the wrong tone of voice, it could really like tick someone, and it could go down. So.
Yeah, because they can't. They may still have.
Is it hot right there?
Pardon?
Is it hot right there?
It was a little warm, but I'm good.
You good? Cool.
So, I see. I study mood disorders and animal models, as well as addiction, which is probably the hardest to get compliance, because you're dealing with an individual who may have been court mandated to take this medication, and of course they still want it. So that's like
Right.
and besides, there aren't very many pharmaceuticals that work for, say, cocaine addiction or anything. But there are behavioral modifications, and if you can get a good history on this individual, you can call them instead of them having them call the suicide hotline, try to get in touch with them. I was gonna ask you if these individuals are alone, if you've just been wearing some sort of, everybody now has I got my flip
Yeah, we were talking about that before. They
Yeah.
don't like things on them. They don't like things on them. They don't want to wear things. That's why I switched to the sensors and motion detectors. Because if they don't have anything on them, they're walking in the room or something like that. A motion detector could detect them.
I think you could get a lot from locomotive. In the biz where we call it locomotion, essentially certain kind of pacing,
Yes.
repetitive movement, or freezing kind of, it's 12 minutes, but they haven't moved from place to
Right.
yet.
We had someone that he throws water. If you're new to him, he'll throw water at you just to see your reaction. And from there, he'll size you up to really how he starts to talk to you, what types of behaviors. Really smart guy. That's his approach to really getting to know people. Throw water. But at the same time, he was also suicidal. So you really need to be able to really prompt him properly, because we have many direct support professionals that were able to prompt him properly, and certain based on his behavioral support plan, and some that did not, just didn't work. So
sorry, I was gonna ask, do you have like analytics of your outcomes? Like, are they?
yeah. So as they document, and so this application on the back end for behavioral specialists and what the direct support professionals documented is a customized form. So it's customized based on the individual. So they document, and then reports are generated based on what was documented, and that's how it's easily shared. And we're trying to get to the part where it can be any type of report is created like on the fly, which is really difficult right now. But technology is getting better there, where you can like start to track how many times someone threw water on something, or threw water. You can't can't really
Yeah, I was
start to
thinking
track
more
that.
like,
You
you
know?
know, comparisons to your program and your approach to like a traditional approach or even an institutionalized approach, and looking at demographics data, like, you know, certain age groups, certain races, that type of stuff, because I've never heard of anything quite this effective. It sounds very effective. But I wanted to see if there's been like any, like, have you actually taken what you're doing and compared it to another model?
Yeah, all those models I just showed you.
But none of those models actually had what you had. That was the point.
Oh no, not even close.
Yeah.
They so like so Clear Care, they're so we can actually check out Clear Care because they have the most they're trying the hardest to really figure this thing out. So so what they do is they focus on their marketing is so just give me a website. And so they actually just released their mobile app not too long ago. So it's called Clear Care Go. So this is their really all the features that's included in their application. So they call it they do employment screening. So we could look at their employment screening. And so they actually just bought a company to help do background checks for employees, but they're missing the main point of the turnover. You still need to train these people, not only on state regulations, but you have to train them on the individual that they're caring for, which takes a lot of time. So they're still missing that main component of training.
I mean, my employer just bought Kindred, right? Just they're moving in the direction of home health, but
Yeah, I know Kendra.
yeah, Kindred. I mean, it's still antiquated, and there's nothing like this going on at all.
I know. Like I said, I used to work for the government. I research technology for a living. Any type of if you have any type of idea, we could research the patent database right now. What I used to do is I used to research technologies, and I used to tell the inventors if it was novel or not. So that's what I did for home health care. I researched all what's available, and then I started to create solutions that were missing. So that's how I created a single solution that based on state regulations, which is really the key here. It has to be based on state regulations, so that an auditor, if they come in, they can check what you're doing based on what they're looking for. So when state regulators came in and audited my agency, they were able to look inside the software and able to do their audit right away in a lot more efficient manner. So we can also look at their overtime tools, right? So overtime, it's really dynamic. It's not only training, because if someone quits or calls out, which happens a lot, you have to match them up on the workers that are available with the needs of the individual. If you're filling in someone with behavioral issues, it can get bad fast.
Right.
So what you're doing is you're still having that overtime problem because you don't have a pool of people that are trained not only in the state regulations but trained on the individual that needs specific supports.
And how disruptive it is to that person, you know,
Exactly.
to have a change like that. So notice.
Exactly, it's not good.
Yeah.
If you tell somebody, okay, sorry, but this person called out, you got this new person here. I know I didn't tell you ahead of time. That's not good. especially someone here which doesn't know, because it's going to get bad fast. I've seen it. So the thing to do right here in an overtime situation is to be able to have that pool of workers that are already trained, but also continuously have increase the social capital of that individual. Let them know that there are other people in the local areas that understand their behaviors. Bring them into their lives at random instances. Not random, but in public places. If they are going to a public event, introduce that direct support professional in that area. And all they'll know is, okay, this is a stranger, but they'll know that they met that person. So that's the way of establishing rapport. We're able to do that with technology. We're able to dynamically schedule people that they're meeting at certain places. But that was all I wanted to go over this month. Next month, we'll talk about how we'll do a deeper dive into how we're actually incentivizing the workers.
Oh, so
And
that next month.
yes, and how we're paying, how when money's crowdsourced, how the money flows to the debit card system. Right? And that's through blockchain.
Really?
So that's next month.
That's cool.
That's going to be exciting. Part of my team will
use
actually be
digital
here.
currency?
Yeah.
Or just, wow. Yeah, this is cool.
So that's next month. Part of my team will be here next month.
Awesome.
So hopefully more people come.
So you don't know how many are gonna watch.
Yeah, we don't know.
Well, a lot of people are SVPs, right?
Yeah, a lot of people. So